Yes.
Okay, so thank you so much for the invitation to speak here. Many of you know I'm a native Tennessean and I am back in Memphis a lot. And I thank you for the invitation to speak today. And I'm going to talk about improved survival in cancer, but continued disparities. Planning the future with precision medicine, which we are all accustomed to now, but assessing the past through the rearview mirror. So making sure that we are incorporating what we've learned over the years that can influence the importance of what we're doing in care as well as clinical trials, but remembering how past influences can affect our success. So we must remember some of the things that have happened in the past. I have no disclosures for this program, and these are my objectives. The poet James Baldwin said, "Know from whence you came. If you know whence you came, there are absolutely no limitations to where you can go." So our past certainly can influence our success of new areas. So slavery, we know that more than 400 years ago, slaves were brought to America. They were sick. Some had died en route. And yet, when we talk about healthcare, we're talking about disparities in healthcare and disparities in our success as well as availability to healthcare. So we've got to think about that there are influences in the past that can affect what we are doing now. Uh, the next area is exclusion of healthcare providers. So the National Medical Association was formed in 1895. At that time, Black doctors were denied membership in a number of medical societies and organizations, and therefore formed their own organization in Atlanta, 1895. And the NMA currently is the oldest and largest organization representing African American physicians and other health professionals in the United States. So it's really very important to collaborate with members of the NMA in our cities as well as nationally so that we're all working together on the process of providing health care, but also clinical trials in our cities. For example, with the NSABP, I had a group of Black doctors in Philadelphia. They were all primary care physicians, and we were doing a number of studies. We collaborated with the NSABP. The Black primary care physicians screened patients, and I shouldn't say patients, screened individuals for a prevention program and a prevention clinical trial. And these doctors actually interviewed and submitted um, clinical trial forms on more than 1,100 patients. These individuals would not have come to the cancer center for this breast cancer prevention trial, but yet they would do that in their primary care physicians' offices. And that allowed for one, a larger number of patients on the prevention trial, but two, referral of patients for the uh, cancer clinical trials. So it increased our overall input into the cancer center for African American individuals. So we need to collaborate with all individuals in the communities, and especially minority physicians who can have a lot of influence. Now, another area that we don't talk about much, and that is the 1910 Flexner Report. It was a landmark study, and what we don't influence or talk about a lot is that the Flexner Report was responsible for, or partially responsible, at least for the low number of African American physicians currently. And that's because of 7 Black medical schools, 5 were closed, and only Harry Medical College and Howard University School of Medicine surviving the Flexner Report. However, what is in the report also is that the statement, Blacks should be trained in hygiene rather than surgery and specialties, and should mainly serve as sanitarians whose purpose was protecting whites from diseases like tuberculosis. And um, many um, medical schools use that information, and consequently, there was a low admission of Black students into other medical schools, and therefore a low number of Blacks in medicine over the time period. Another important fact for cancer treatment is the National Cancer Act of December 23rd, 1971, when then President Nixon, as you can see him here, signing that legislation. And there has just been, in December of 2021, 50 years of the National Cancer Institute program since the National Cancer Act. And with that, the National Cancer Advisory Board, the National Cancer Centers Program, so that now we have 72 NCI designated cancer centers, the cooperative group program, such as SWOG, Alliance, ECOG, Akron, and others, and the SEER program, where data allows us to do research on a number of factors. So we all know about the SEER data. And with the 50 years importance of the National Cancer Act. Now, when one talks about disparities, one cannot leave out Dr. Jane Cook Wright, who was one of the founding, we were told fathers, but nobody really emphasized the one founding mother associated with ASCO. There were 7 researchers who decided that we needed to share information, and of course, one African-American woman. And here are many influences of Dr. Wright and her father, and members of ASCO and the National Medical Association giving her the Lifetime Achievement Medal, and consequently, Dr. Jane Cook Wright. Now, she was very responsible for research, and she was the first to say that if we need to talk about patients and how we provide information and clinical care to patients, we must study their tumors in the laboratory. So she actually started the program of precision medicine, and a lot of her work with methotrexate and tumors in the laboratory, very important today. Medicare. So you ask, well, why am I talking about Medicare and I'm supposed to be talking about disparities in cancer? Then President Johnson, signed the Medicare bill July 30th, 1965. The National Medical Association was very important in the uh, writing of the Medicare bill, and the president of the NMA at that time reportedly went to Kansas City with former President Johnson to sign the legislation, and he offered former President Truman the first Medicare card with his wife, Bess II. So Medicare, very important. Well, why am I talking about Medicare and cancer? Well, Medicare was a major force for racial desegregation in healthcare facilities, including those in Memphis. Um, it had been passed a year after the Civil Rights Act, and consequently, enforcement of the Civil Rights Act was a condition of hospitals participating. So, those hospitals that had two entry doors, one that says whites only and another saying colored, all of those signs were removed prior to hospitals participating in the Medicare reimbursement program. But what was important um, for disparities is that, so those things were important, but hospitalization rates increased both for whites and for blacks, and therefore greater services available to people to influence participation. Now, I was always interested in racial differences in cancer, and my colleague and I looked at the annual direct spending for patients. So, for those under age 40 to 64, note that private insurance covered 72% of cancer costs for whites, but 62% for blacks. Medicaid covered smaller amounts, 3.5% for whites and 21% for blacks. So just paying for cancer care, whether the individual was Medicare eligible, that's age 65 and older, or with certain conditions, or the patients had private insurance. And note that Medicaid covered for Black patients a much higher amount than Medicaid for whites. So differences in cost and differences in payment for cancer-related care. Um, this is was given to me by Dr. Freeman, and what he said, the causes of health disparities were multifocal, including the tumor environment, but also there were differences in what we did for prevention, early detection, all the way through the continuum of survival and mortality. And therefore, if we were going to influence cancer care, we needed to make sure we include everything through the continuum of care, such that we are providing services at all levels. And of course, that influences our cancer care delivery in the country and our research at this time. I mentioned the workforce previously, and for workforce diversity, note that the number of Black uh, clinicians in the country, that percentage has not significantly changed over decades, with just minor increases in the Hispanic or Latino practicing clinicians. So we need to increase the number of doctors that we are training. It's well recognized that individuals who are members of disparate communities, that the number of patients that are treated in those communities has a higher percentage in individuals who know those communities than in others. So increasing the number of clinicians important, and the Accreditation Council for Workforce for Medical Education, ACGME, has said the goal of workforce diversity is to achieve health equity. Inclusion is the tool, and health equity is the means to achieve elimination of healthcare disparities. So we need to train more doctors, and therefore the term DEI. And ACGME says that healthcare institutions need to acknowledge and contextualize the issue, accept and own it, and then develop the tools for increasing diversity in the clinician workforce. So that is something all of us have to do. So I mentioned the um, the Cancer Act of 1971 started collecting data, and it was first reported in 1975 that there were differences among whites and blacks, and that blacks had higher mortality rates. About a 2000, there was the initiation of collection of data on more racial and ethnic minorities in the country, and therefore collection and reporting of data on many individuals and communities, which has continued. But note that African Americans still have the highest mortality rates, although there has been a continuous decline over the years, but still more, and we have to therefore focus. So, how can we address disparities in cancer outcomes? Well, there are lots of different things, but community engagement and outreach, increasing clinical trials participation, all of these are important, as well as unconscious bias and other um, topics that prevent participation in clinical trials. And in fact, in patient reported data, it is recognized that the patients say they wanted to participate in clinical trials, but nobody asked them. So we've got to make sure that we include everyone. So for racial disparities in healthcare, we can have the influence of minority professionals having a low number, research studies not including, and lower rates of comprehensive insurance for patients, cost of care, and others. And then redlining, where individuals have no access to healthcare facilities in their communities. So, very important. The ACA has been important for cancer disparities, and in states that have expanded through the have Medicaid expansion, it has been shown that implementation of Medicaid expansions as part of the ACA differentially improved African American cancer patients' receipt of timely treatment and reducing racial disparities in access to care. So political events have also shown that cancer care and the lack of cancer care and the influences in disparities can be addressed at the state level. Another area is the All of Us research program, which started by NIH in 2018, and it was to influence participation of well individuals as well as patients, and it was to collect information over a 10-year period on over 1 million individuals. Well, just last week, there has been a report that more than 500,000 individuals have been accrued to all of us. And now there's going to be the opportunity for researchers to get information and tissues for clinical investigations. And it's to learn how individual differences in lifestyle and biological makeup and others influence disease process. So for our researchers, let's get our proposals into NIH for participation in all of us. The President Biden reignited the cancer moonshot actually a year ago. It was February 2nd of 2022, where President Biden and Vice President Harris delivered this information at the White House to decrease the death rate from cancer at least 50% over the next 25 years. After that, the President's Cancer Panel, which I was a member of at that time and have just finished my work on the President's Cancer Panel, provided these 4 critical goals: to improve and align communications, to facilitate equitable access, strengthen workforce collaborations and working together, and then create effective information technology so that we can communicate better and provide information to take care of patients as well as participate in clinical trials. Complete report can be accessed at this site. You can download a copy, or if you want a written copy, leave your information and a copy will be mailed out to you. The President's Cancer Panel, very important, and the focus was increasing screening. And if we can increase screening, then we have a better chance of finding a cancer at an early stage, where the outcomes are likely to be better, or actually preventing cancer occurrence in, for example, in cervical cancer or colorectal cancer. Now, another group of patients that we don't discuss frequently is that of sexual and gender minority patients who have increased incidences of certain cancers as well as poor access to care. So another community that we really need to worry about and focus on. A survey was administered by the ECOG Akron group, and we surveyed clinicians regarding 1, what has been their experiences, 2, reservations in caring for the SGM community, and 3, suggestions for improvement in SGM cancer care, and 4, additional comments. We collected the data, and the conclusion was that clinicians have minimal experiences with SGM patients with cancer, but desire training. Training the entire workforce may improve the trust and outreach efforts and cancer care delivery to this group. And these data have been reported, and we are working hard to develop guidelines on how we provide care to the SGM population. Following that collection of data, medical students who work with us training the population to come of new physicians wanted to do a similar analysis of medical students. What did they think about? So the background was to use the previous concept that I discussed for clinicians and see what medical students thought. Well, they added some more questions, demographics, and so forth. And conclusions from this study were presented at ASCO and by the medical students. And with the conclusion that while the medical students were comfortable, most of them are not confident in their knowledge and training. And therefore, there was a suggestion that medical schools need to think about increasing the educational process for medical students regarding SGM care. So NIH has a sexual and gender minority research working group, and it is reporting to the NIH Council of Councils. And I'll give you just a couple of things from their work. I participated in this group September 7th last year, and you can get a full copy at this link. And the messaging and messenger are both important, and consequently, we need to make sure that we're incorporating patient advocacy in what we do. So integrating minority populations and gender into the Jefferson plan incorporates working with all of the things that I've discussed, the community, partnerships that we need to develop, the clinical science, the basic scientists, our data management group, and all of this in focusing on the populations in our catchment area and therefore in our community, so that we are important to our communities as well as our national areas. So with that, I am again very happy to answer questions, but thank the organizers of this program for including me in the speaking group today. Thank you so much. And yes, I love Memphis.
Thank you very much. Thank you, Dr. Mitchell. She's been very supportive of this program and Memphis on a whole. Now I want to introduce Dr. Lee Schwartzberg, who is probably most integral in West Clinic the way it is there.